All right. Moving on to module A2 in PFTs. But before that, I want to just take a moment and make the rash assumption that everything I said yesterday about axis deviation was spot on and there's no problem. Let's talk a little more about it. I got a couple examples too. So again, we're using this to identify or to verify the presence of hypertrophy. The axis deviation is always going to go toward hypertrophy or away from infarction. It also helps us identify things like bundle branch blocks and again the myocardial infarction as I mentioned. So it's the general direction of current flow during depolarization of the ventricles, and normally it's in that quadrant that is in the lower right, or what we're going to call 0 to 90 degrees, and where lead 1 would be 0 and lead AVF would be 90. We're talking about positive or negative deflection. It's talking about the overall direction the QRS complex is pointing. We can all say that this for sure, I have 12 boxes going up, I only have 2 going down. So it's a relative positive, negative. This one we can't say one way or the other, so it's kind of an oddball one. You won't see that with lead 1 or lead AVF. It's pretty definitive. Okay, so we're good on positive versus negative. So these 4 quadrants, again, this is normal, where they're both up. If I'm in this quadrant, that's a right axis deviation, I end up having lead AVF. It's going from top to bottom, but it's not going left to right. I'm sorry, right to left. It's going left to right. So it's going backwards. So this would be a thank you. Yeah. Huh? You don't have these. Yep. I just want to go back and review. If you want, I'll go ahead and post these slides if that'll help you. With left axis deviation, it is going in the leftward direction, so right to left, lead 1 is going to be positive, but it's also going bottom to top. So it's going a negative deflection in AVF. And then finally, they're both negative. If we're in that, this slide calls it northwest, you call it indeterminate, you can call it no man's land, whatever. So that's what we're talking about, the right, left, and here again another term for it, extreme right axis deviation. Just another color picture of it, so you can kind of get an idea of what direction we're going, and they have the little ones there also. And that's blown up for you. So again, pointing toward hypertrophy, away from infarcted areas, and since they're perpendicular, we can use these two. Another way of looking at it is to just draw it here in lead 1. I have more on the, it's on the left side, or on the right side. Here it's on the bottom, so when you blend the two of them, you can end up seeing where the deviation is, and that's normal. There's left. Again, we talked about left ventricular hypertrophy, or a right-sided, or in this case even an inferior MI. On a right axis would be a left-sided MI, like the lateral wall, or a right ventricular hypertrophy. And the weird one you end up having is where they're both negative, and that pacemaker is probably the most common one you'll end up seeing with that. So, knowing all that, here's a 12-lead EKG, a sampling of the various tracings in each of the leads. Where is my axis deviation, or is there any axis deviation? Are they? AVF.
Oh, AVF. Oh, one's down.
Okay, so which is it?
That is...
If I have a positive in lead 1, meaning it's going right to left, but AVF is negative, meaning it's going from the bottom to the top. No, we're not talking about what part of the heart. We're just saying what's the access deviation. It's left.
Wait, how did you determine that? I'm sorry.
Okay, lead 1, right to left.
Okay.
It's going this way,
Yeah.
but AVF says it's going this way.
Because it's not
It's a negative deflection.
okay.
So if I were to combine those two, I have this, and I have this. It says it's going right to left, but it's also saying it's going up. So it's got to be in that quadrant. Starting to click a little? Thank you for nodding your head, Sarah. I know you're lying, but it's okay. How about this one?
That one's not, they're both positive.
This is positive.
No, that one's not, I'm looking at 2, man.
Lead 1 and lead AVF, perpendicular. This says it's going left to right. That's saying it's going top to bottom.
Going in this quadrant of the upper
So what quadrant is that?
right.
No,
Lower.
lower left. This quadrant here.
But I thought lead 1 was in the upper quadrant.
Lead 1 is saying, are you going right to left or left to right?
Okay.
So it's saying I'm going right to left. It's going in a normal direction.
Yeah.
The other one is saying, is it going up or is it going down? And this is going up.
Okay.
No, I'm sorry, it's going down. I had it backwards. This is going this way and this way. So it's got to be this one down here.
Okay.
Right axis deviation.
Looking at 1 in AVF.
That's all you're looking at for axis deviation, yes. We won't talk about bundle branch blocks yet. We just know they got the bunny ears. One more. One is up, yes. But AVF is negative.
So it's in left.
So not.
Left. Just a matter of practicing. Okay? I will post these slides, yes. One more.
Lead 1 is down.
Okay?
AVF is up.
So it's going this way.
Right.
No,
Well,
this
left.
way.
Left.
Left to right. And what about up and down?
Up and down.
Down.
It's going down. So what's going this way and down would be
Right.
right axis deviation. Okay. So let's talk then about our getting into our pulmonary function. This is where you guys should end up being. Have you guys had a chance to go online and take a look at the AARC's clinical practice guidelines? You may want to take that time. Go to aarc.org, look at resources, I believe, or education, and you'll end up seeing the clinical practice guidelines there. They're going to come in handy for you as time goes on, and a lot of what we're going to talk about in this course is going to be referenced back to them. And Egan has them. Egan? Oh, yeah, Egan has them outlined also. Some other things that are out there, and Lori will talk about this when she gets to asthma and COPD, but for asthma, there's an expert panel report, what's known as EPR3, because it's the third expert panel that they've come across. And it basically talks about the guidelines and diagnosis for bronchial asthma. Okay. And there's also some standards through the American Thoracic Society. A whole slew of them as far as spirometry and lung volume testing and single breath diffusion process. And then the gold standards are the ones for COPD. And we'll reference them more and more as we go along. They're very lengthy. Don't print them out. But everything that we teach you related to those two, asthma and COPD, can be found there. All right. So some stuff out of clinical manifestations. Talking about normal values, talking about expiratory flow measurement. That whole process of, is it a restrictive disease process where we can't get the air in, or is it an obstructive disease process where we can't get the air out? And then also talking about diffusion capacity, which I know you have found so exciting from Module C and 1050. And then also looking at some stuff out of Egan. So what we're going to do is have 4 different aspects that we're going to look at. We're going to have you do some simple spirometry. We're going to have you measure the maximal inspiratory and the maximal expiratory pressure. I'll explain what those are. And we'll have you measure the peak flow, as well as the force vital capacity. This was flow vital capacity, and get both those measurements there. Some of the objectives that are there. Again, you should be able, from a spirogram, be able to determine what the force vital capacity is, what the FEV1 is, and therefore determine what the ratio is, and be able to state whether it's an obstructive or a restrictive defect. It all goes back to Lori's Module D. Let's see if I can get this to go.
And we're back to the action here in Indianapolis. Another strike by Gilbert. Brian Lass needs to be perfect here. Seems to be a slight delay. Oh my! Not the official tools of bowling. The official tools of NASCAR. Craftsman at Sears.
Oh boy. Is that washed out or is that me? Can you see it okay? It's a little bit, to me it's a little bit too white. Is that better? But now it wants to be nap time. Get my binky and...
Module D and
50.
Okay.
That was the PFT one? Yeah. Why do I know this? That's scary.
I don't know.
All right, so why do we do pulmonary function testing? Primarily, we're looking for the presence of lung disease, but then also sequentially, we'll see if, what the severity is, and also the course of therapy. Is what we're doing for the patient doing any good? If it's not, why are we doing it? Or should we be doing something different in the process? You'll also see it in the hospital as far as just a bedside screen. Preoperatively, the anesthesiologist may want to know where this patient's pulmonary status is. The worst time to find out that they have some lung disease is in the middle of surgery. So they want to have something up front that they can say, okay, I'm going to anticipate this patient may need some alteration in their anesthesia delivery, may need to have some, we may have to expect them to have some altered recovery process in the post-anesthesia care unit. So there's bunches of reasons why we'd end up doing it. Primarily it's to look at the extent of any lung disease present. Our bedside assessment that we're going to use, again, we're going to go back and reuse that respirometer. I think Lori had you use it when she was talking about measurement of minute ventilation, and you counted the respiratory rate, and you determined the average tidal volume, blah, 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 blah. We're going to use that device again. We'll also use a handheld spirometer that can be used at the bedside, can be used as a screening tool in the community. We'll also have you guys utilize a peak flow meter to measure Amber Eye's peak flow. And that is something that we'll use with asthmatics frequently, and I think probably covered that before. We looked at determining the zones of peak flow, whether it's in the green area with yellow or red. Actually, the other way around, green, yellow, red. And then we'll also use a manometer to measure for pressure changes, for the maximal inspiratory and maximal expiratory pressure. And again, we talked about the different reasons we would use it. Certainly in the ER when an asthmatic comes in, we want to monitor their peak flow. Ideally, when they're walking in the door, yes, I know they're in distress, but if we get a measurement, we can at least have something to make a judge whether or not they're getting better post-therapy. We'll also use it in neuromuscular disease like Guillain-Barré or myasthenia gravis to see if the muscles are too weak and they need to be mechanically ventilated, intubated and mechanically ventilated. And we'll also use it on our ventilator patients to assess whether or not they're ready to be liberated from that ventilator. So every morning we'll do an assessment of where they're at breathing spontaneously. It's called the spontaneous breathing trial. And we want to say, can they come off the ventilator today? Or is it another day we're going to have to stay on the vent? Simple spirometry, again, does not include any lung volumes, but it's typically used to measure the forced vital capacity, and from that then we derive all the other values, the FEV1, the FEV2, whatever, as well as the peak flow. Flow volume loops give us an idea of where we're integrating the flow and the volume tracings instead of just doing the volume versus time. We're using the volume versus flow. And maximum voluntary ventilation, we don't do that much anymore, but it gives us an idea of how a person would respond to stress. Okay. Usually if they're a COPD patient or an obstructive disease patient, we'll automatically do a pre and post bronchodilator. So we'll do a test and then we'll do the post. We'll administer a bronchodilator and repeat the test. And again, that's where we're looking for a 12% change in the FEV1 and a 200 milliliter change in the FEV1 to consider it to be a responsive airway. And we talked about pre-op. A complete PFT does not only that simple spirometry, but it also measures our lung volumes and capacities. So we're going to use something like helium dilution, something like nitrogen washout, something like the body box to be able to determine the FRC, and from that then we can determine what the residual volume and residual volume to total lung capacity ratio is. Blah. Complete PFT will also include a diffusion study to evaluate whether or not there's good diffusion. The normal value again is what? 25 milliliters per minute per millimeter of mercury of carbon monoxide. Sound vaguely familiar? If we're doing body box, we have the ability to measure resistance as well as elastance. Bronchial provocation. I don't know if Lori talked about that or not, but I'll go ahead and make mention of it. Bronchial provocation is where we suspect the patient may have reactive airways, may have asthma. We're not sure. They don't manifest the normal signs and symptoms of asthma, but it kind of looks like they may have it. So what do? We have them inhale a medication that induces an asthmatic attack. How nice is that? And we're looking for, in you and I, assuming you and I don't have asthma, we wouldn't see a response. In these folks, we would end up seeing a response, for which we can treat immediately with a short-acting beta agonist, like albuterol. Can be a medication, can also do it with exercise. Some folks who have exercise-induced asthma, just the fact of them putting them on a treadmill and having them run, we can induce an asthmatic attack for the same exact reason. Pulmonary stress testing, just like a cardiac stress, where you get on a treadmill and you run, you see at what point you start having chest pain or seeing ST elevation, ST depression. We can do the same thing with a pulmonary patient. We can measure their oxygen consumption, their CO2 production, determine their respiratory energy level as far as how much energy they're using to breathe, and get an idea there. And similar to the pulmonary stress, as far as measuring oxygen consumption and CO2 production, We can do this in a resting state, patient lying in bed, and determine how much energy they burn on a daily basis. Why the hell would I care about that? Well, we're going to find that COPD patients specifically, diet makes a huge difference. What they eat is going to affect as far as how they breathe. And if they're on a mechanical ventilator, what they eat is going to impact how easy or hard it is to get them off the ventilator. High carbohydrate diets for a patient who can't remove CO2 is very deleterious. It's going to have a hard time clearing that CO2 because they don't have the lung function. So a high protein, high fat diet actually is better off for them. I think we might have talked about, I don't know if we did or if there was a second, about Pomocal. It's actually a shake, yeah, but that they can end up drinking, or we can end up, if they have a nasogastric tube in, we can end up administering to them. So there's a bunch of different tests we can end up doing. We're going to go through some process of making sure that our equipment is functioning, and every day that we do pulmonary functions, we're going to do a quality control on it just to make sure that it's operating correctly. We've got to make sure the patient's prepared. We want to make sure that they have not taken their medication, that they have not smoked. One of my students one time came in and said his mom had a PFT done, and her diffusing capacity was like hugely low. And I said, oh, okay. Does she smoke? Well, yeah. Did she have a cigarette? I didn't ask. So we went home and said her mom was so nervous about getting the test done that she had to have a cigarette going to the doctor's office to take the test. It's like, well, you just blew the test. We're going to go ahead and perform the tests to make sure that they're done correctly. That's what validity is going to tell us. We're going to take a look at multiple results. We're going to do not one forced vital capacity, but at least 3, but no more than 6, to make sure that they're getting some reproducibility, that the numbers are making sense, that the patient is able to do the same forced vital capacity, the same FEV1 repetitively. And that's where we're going to look then at selecting the best test, and go ahead and then we can get some interpretation and make some recommendations. Somebody ever seen something like this? It's called a fishbone. And it basically is one way to solve problems, or in this case, to determine that our spirometer is working correctly. No, I don't expect you to memorize this. But recognize that certain patient characteristics are going to play into how well the results are. It's kind of hard to do a good PFT on a 2-year-old. Right? Some of the problem could also be us, or the person doing the testing. If they're not well trained, you're going to get garbage information. Believe me, I've gone to my family physician and I said, can I have your medical assistance for about 10 minutes and I'll show them how to do a PFT correctly, because I've seen them do them and they're terrible because they're not trained correctly. They don't put it. When you're doing a pulmonary function, you have to yell at that patient. You want to get the maximal effort out of them. But I don't want to hurt their feelings. I don't care about feelings. Get the number. So again, are we doing this correctly? How about that open and closed system? If I have a leak in the system, my helium dilution is not going to work really well. Okay. And then also the machine that we're using itself has it done the proper quality control. There's multiple factors that are going to go into whether or not this is done correctly. And unfortunately, again, especially in the physician's office, they're not all paid attention to. And this is just another way of looking at it. This is from the ATS. So what we're going to do is use a calibrated super syringe to be able to verify that the volume that we're thinking we're measuring, we're actually measuring. It's called a super syringe because it looks like a syringe. And it goes ahead and we're going to make sure that the value is plus or minus 3.5%, which works out to about 105 milliliters. So if I have a 3-liter syringe, a volume of 2.92 is within that 3.5%. We can use a stopwatch to evaluate time. We can use a flow measuring device called a rotometer to be able to evaluate whether flow is accurate. We can use a barometer to be able to measure the pressure. And as you know, with the helium dilution, nitrogen washout, there's analyzers that measure those specific gases. So lots of things to double check on, and that's done usually by the pulmonary function tech in the morning. This first bullet point, that we should use only devices that meet the American Thoracic Society, European Respiratory Societies. They all do. You couldn't sell a spirometer in today's environment unless it meets these criteria that said that they should be done. And again, we want to report things appropriately. And I think we've talked about precision and accuracy previously. Precision is it's able to reproduce a value. Accuracy is it towards the center of the bullseye. So here I can have accurate, but it's not precise. I can have precise, but it's not accurate. We want both. I think you might have seen that slide from 1060 because that's where I stole it from. So here we have, they're accurate, but they're not very precise. So it's if you average them, it's where it should be for a 3-liter syringe, but they're all over the board. We would rather have something that is both precise and accurate. This is precise, but it's not very accurate. It's not near the 3 liters that we want it to be. Not a chance in the world that you would need to memorize this. But there are for each test that we do, there's a range of accuracy that we have. Can we just leave it at that?
Yeah.
Good. For our purposes, we're just going to go with daily, because if we do it all daily, then you're doing it wonderfully. But there's various things, again, everything from the software, whenever it's updated, to make sure that it's functioning appropriately. We talked about preparing the patient and preparing the therapist. So, simple spirometry measures the force vital capacity, can measure a flow volume loop, and we can use it to do maximal voluntary ventilation. And we talked about all the things in a complete PFT. I'm skipping through these, they're kind of duplicate slides. So, again, we talked about the patient, preparing them. They should know how long it's going to take. This is not a 2-minute test. This is going to be an hour that you're going to be here. Okay, because there's multiple things that we need to do. Don't take any meds within 4 hours. Okay, so if you're scheduled to take the meds, come on in. We'll have you do the test and take the meds after. 12 hours for some long-acting meds. Don't smoke within an hour. It's a shame, but you can't consume alcohol for 4 hours. Because why are we drinking wine at 9 a.m.? Really? No. No vigorous exercise. I'm all about that. Thank you very much. And no large meals. So there's different things we want to tell them to prepare them for doing a pulmonary function study. Get all of our demographic information, remembering that PFT reference standards are based upon age, gender, and height. We record the weight, even though it's not something that is used. And there are tables for various ethnicities that are available also. So if you have somebody who's from the Pacific Rim, there's different quote-unquote normal values for them versus somebody who may have a different background. And again, you can use your arm span divided by 1.06 will give you a pretty close approximation. Why would I want to do that? I got a double below the knee amputee. How tall were you? No, we can't do that. We're going to measure that. I had a therapist do that. It's like, really? Positioning the patient, they ideally should be sitting in a totally upright position or standing if they're a child, less than 12, or if they're morbidly obese. Feet flat on the floor, loosen clothing. Please, no gum or food in the mouth. It's kind of hard to take a deep breath in when you got a piece of gum in there, right? Head up, don't bend. And then we want to, if we're having on a kind of a long-term basis, we'll have various other monitors like pulse oximetry available, and obviously anything that we're going to utilize, most of it's disposable, so it's not an issue. Nose clips, you don't necessarily have to use them, but in many cases patients have a tendency to want to exhale through their nose, so you're not getting the full volume. We want to make sure that they fill and or empty their lungs appropriately. So for various tests like the forced vital capacity, take a deep breath in, deep, 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 to maximal inhalation, and forcefully exhalate until you can't blow out any more. Sealing of lips are tough for a lot of the aged. They don't have really good control, so there's lots of leaks. We got to evaluate that. For some of the tests like the peak flow meter, you don't want them to block the opening where they're exhaling. It's kind of like a duh. It's not going to measure really well if you're blowing against your hand. Making sure that they're exhaling slowly if we want, or forcefully if we want, depending, and at full effort. And again, nothing is better than an enthusiastic therapist there yelling and screaming at the patient to work harder. And again, I'm sorry, I think I said 6 before, it's 8. So minimum of 3, maximum of 8. And the reason why no more than 8, they get tired. You start seeing degradation in performance just because they're pooped out. I can't even do 3, and I'm beat. But. And then we're going to evaluate: is it acceptable? Was the test done correctly? And is it reproducible? So again, we verify validity by making sure the equipment is properly calibrated and doing 3 tests. It's acceptable if the test is done correctly, and it's reliable if the results are consistent with minimal variability. If you remember with the FVC maneuver, we just have the patient breathe spontaneously. Take a deep breath in, deep, 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 deep. Now blow it out fast, fast, push, squeeze, squeeze, all the way out. Maximal voluntary ventilation is one that, again, we don't use that much as we used to. Don't get a whole lot of data out of it, but it's basically having the patient breathe as deep and as fast as they can for 10 to 12 seconds, and then extrapolating that, how much air you moved over a minute's period of time. It's kind of like, imagine that you're being chased by a saber-toothed tiger. I can't even do it for 5 seconds. Good Lord. Fast and as deep as you can. And then flow volume loops. I think Lori might have talked a little bit about them. But basically, we're able to evaluate not only the presence of an obstructive disease process, where you'd end up seeing a scooping out of that flow volume curve. We can also tell variable and fixed airway obstructions, and we'll deal with that another day. And we can also look at a restrictive disease process where if blue is what the predicted is, red has been reduced. Not so much the flow like you see there, but certainly the volume. Okay, can't get the air in.
Scooping is COPD.
That would be emphysema COPD. Yep,
What's
absolutely.
UAO?
What's who?
UAO?
Upper airway obstruction. Don't worry about it. We're not going to worry about, all I want is this and that and normal. Obstructive, restrictive, and normal. We're not going to get into the just give you an example. I can have a I can have a variable airway obstruction where the trachea has perhaps some cartilaginous rings that have been destroyed. So I end up having a fixed or a variable airway obstruction extrathoracically. I can have something that's intrathoracically. And I can determine those by looking at the flow volume loop. Later, much, much later, like next fall. We'll come back and visit this again. And again, that's where we don't want to go. So what about the bedside? What can we end up doing? Typically, a pulmonary function is something that's done on an outpatient basis as far as simple spirometry. But we can do some stuff at the patient's bedside. We can do things like you did in the lab, where you measured the minute volume, you measured the respiratory rate, and determine the average tidal volume. From that, you can also generate a inspiratory capacity, inspiratory reserve volume, expiratory reserve volume, and our vital capacity, both in a slow fashion and in a forced fashion. From them, we can then calculate various other things. You guys, based upon your ideal body weight, to determine your dead space volume, so you can determine your alveolar volume. Rapid shallow breathing index is an index that we use at the bedside to be able to evaluate somebody's spontaneous ability. This is the test that we do, or that we monitor, the value that we monitor while they're spontaneously breathing prior to being extubated. Okay? It's the frequency to tidal volume ratio, so I see what the frequency is divided by the average tidal volume in liters, and we can get an index of whether or not they're ready to be extubated. The ones you cannot measure with simple spirometry, gee, I don't know how many times you'll see that question on the test. The functional residual capacity, the residual volume, and the total lung capacity. You need lung volume testing to be able to do that. You can't do it at the bedside. And I know you've never seen this picture before. The lung box will not go away. Just saying.
Explain it a couple more times.
What?
I still don't get the FEV one. I still don't get it. Like
Okay.
how to find it.
See me. We'll go through that one. This is another diagram of it, kind of expressed differently as far as residual volume, your expiratory reserve volume, your tidal volume, and your inspiratory reserve volume, and the capacities that can be accumulated from them. And this is just looking at obstructive, where you end up having an increase in residual volume on the right-hand side. A lot of trapped gas. Yeah, in the restrictive lung, everything's crunched. And we talked about, I think, about the equal pressure point, where there's a point in the airway where the pressure on a forced exhalation extraluminally exceeds that pressure inside the airway, so the airway collapses. And this is why patients with COPD have a forced vital capacity that is less than their slow vital capacity, because that forced maneuver traps more gas, because the airways collapse. That's one of the reasons we teach them to do pursed-lip breathing, is to split those airways open so they don't collapse. Within the lab, we're going to use a respirometer to be able to measure these volumes. Now remember that the respirometer does not, two things. One, it's inaccurate at a high flow rate, so there's no forced maneuver. But more importantly, the way it works is there's small little veins in there, like a weather vane. And if you use a forced exhalation, you can damage it. So the respirometer we're going to use for a slow vital capacity measurement of a minute ventilation, something along that line, where we're not doing a forced maneuver. Volume displacement is what we would use, we may use in a pulmonary function lab. The problem with them is there's leaks that are present. And you're also, remember, measuring volumes at ATPS, but we want to know what that volume is at BTPS inside the body. So you have to go back and correct for that. Fortunately, the machines all do it automatically, so life is easy. There's our vein respirometer that we used, and we can verify precision with the 3-liter syringe, make sure it's functioning properly. Internally, you can see there's those veins. They're connected to some gears, and that's how it ends up working. Not that you care. I think you know how to take a respiratory rate. I think that was one of our PEs that we had last fall. It's a very difficult process, especially on some people who think, are you breathing? Normal respiratory rate. So if we count the number of excursions and watch for 15 seconds, we can end up multiplying that value by 4. And again, it's a complete cycle of a breath in and a breath out. A reduction in respiratory rate we talked about leading to potentially an increase in CO2 due to hypoventilation, which can lead to some acidosis. It also can cause, it's one of the causes of hypoxemia, is hypoventilation. Increased rate does the opposite, and we know that patients with restrictive diseases tend to have a rapid shallow pattern, where obstructive have a slower with much more of a prolonged exhalation. Can't get the air out. And just some of the causes as a review. Notice that head injury is on both lists. It can trigger hyperventilation, it can trigger hypoventilation. And we won't do this. You've done that before. Tidal volume, we know, is about the amount of air that we're moving in or out, and we're going to use the value of 5 to 8 mLs per kilogram of ideal body weight as the average, or what the normal tidal volume range is. And we know how to calculate that. There's actually another formula that we'll introduce that actually is a little more accurate, but this is the one that I think we started off with. And then this is the predicted body weight, which is a little more accurate. And the nice part about this is it puts it into kilograms, so I don't have to do the 2.2, which I kind of like. So either 50 or 45, depending if it's male or female, times 2.3 times the difference between their height and 60 inches. And you can determine that. Reasons why tidal volume would go, and again, head injuries on both sides of the track. We're going to measure tidal volume using a volume measuring device, a one-way valve system, and a mouthpiece. And we're going to measure the amount of gas that is moved. Connect the mouthpiece to a filter, and the mouthpiece then and the filter to the one-way valve system. And we're going to go ahead and make sure that the one-way valve is going in the right direction. So if I'm not seeing measurements of that with that spirometer, maybe I got it on the wrong end. We'll play with that. We know that the one-way valve, as it opens, patient breathes, and as they exhale, I want to have that, so it's a one-way valve in that direction. I want to have the respirometer there. And on exhalation, then I'll collect that. And are we comfortable with how to read these things? Remember, that was always a challenge to find out what the actual minute ventilation was. It's like a scale of a clock. For each revolution, the short hand goes around. That's one liter. It'll move the yellow hand if you're using the Hale scale, which I think is all we actually have. One space. And then you can end up extrapolating the smaller portions by looking at where the large hand ends up. On patients in the clinical realm, we may need to have something else other than just them using a mouthpiece. Some aged people can't keep their lips tightly sealed, so we could use something called a mouth seal that'll actually collect their air without having to have a tight seal on the mouthpiece. We can use a mask. We can tube them. No, we wouldn't tube them, but you measure it on a patient who has an artificial airway in place. And minute ventilation, it's the amount we do in a minute's period of time. Normal is 5 to 10 liters per minute. And again, both the respiratory rate and tidal volume play into this, so the causes of an increased or decreased are similar to what you had there. So one of the things that you'll do with Amber and I is we'll measure the minute ventilation, and the respiratory rate to determine an average tidal volume. And we know that somebody who has an increase in minute ventilation, that's going to cause their PCO2 to be decreased. So hyperventilation causes a reduction in carbon dioxide levels. Usually nose clips, you may need them. So have the patient breathe a few breaths, then go ahead and reset the respirometer and count for a minute, as well as counting the respiratory rate, and then go ahead and evaluate what the value is for minute ventilation. This is the value I was talking about that we do at the bedside, where we end up determining their tidal volume in liters and their respiratory rate, and it's the frequency to tidal volume ratio, and normal value is about 100 or less. To get above 100, that means they have a rapid, shallow breathing pattern. It's probably not going to be effective to ventilate spontaneously. This is what it says. Alveolar volume we measured, or we estimated based upon the dead space. So 60 to 70% of the tidal volume is alveolar volume. The other portion, 30 to 40%, is dead space, both anatomic and alveolar, which is what we're going to call physiologic. And we can measure the physiological method technically, although we don't do it, using the Ingolf modification of the Bohr equation, blah, pickle, pickle, pickle. The mixed expired CO2 subtracted from the arterial CO2 divided by the arterial CO2. A little bit of a cumbersome process. More often we use the estimation of roughly knowing that the end tidal to arterial gradient is 2 to 6 mLs, 2 to 6 millimeters of mercury, excuse me. As that value becomes larger, we end up having a bigger dead space fraction. I think we talked about that. We talked about capnography. And we know how alveolar minute ventilation is going to affect PCO2, as we said previously. Why is it such a big deal? Because I can have the same exact minute ventilation and have an alteration in my PCO2. So here I have a patient breathing 12 times a minute, 600 tidal volume, meaning I have a 7.2 minute ventilation. I have a 200 ml dead space, so I have a 4.8 liter alveolar minute ventilation. That's generating a PCO2 of 40. What would happen if I increased the rate to 30, but the minute ventilation didn't change? Well, now I'm breathing more as far as the number of breaths, but I still have that dead space there. So my dead space ventilation would go up, and I would find my PCO2 would go up extensively. Okay? And if we do the math, this is what we end up coming up with. And here we end up having the tidal volume only being 240, but I have, of that 240, 200 is dead space, so I may actually effectively only moving 40 milliliters per breath. Not very good. Okay, unlike dogs, who seem to ventilate just fine when they pant, humans don't work that way. So you need to assess not only the minute volume, tidal volume, and the respiratory rate, but you also need to take into account that dead space in the process. Inspiratory capacity, again, that's the magic box, not magic box, the lung box. This is where we're going to use it for something called incentive spirometry that we'll talk about later in the semester. What we're actually measuring is the inspiratory capacity, from a resting exhalation to a maximal breath in. We know about the inspiratory reserve volume and expiratory reserve volume. It's not something we usually measure at the bedside, but that's part of that lung box. And the flow vital capacity, 60 to 75 mLs per kilogram. Ideal body weight. So if we normally breathe 5 to 8 mLs per kilogram, our capacity is huge compared to that. So we rarely use but a fraction of our total ability to breathe. And how would we instruct the patient to do a slow vital capacity? Take a deep breath in, deep, 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 deep. Keep it going, go, 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 go. Now blow it out nice and slow. Push, push, squeeze, squeeze. Keep going, go, 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 go. All the way out, all the way out. You don't have to do that part, but not forcefully. That's why it's called a slow vital capacity. Okay. And normally, again, that vital capacity should be 60 to 75 mLs per kilogram ideal body weight. The minimum value we want to see is 15. If it's less than 15, that's an indication that the patient probably cannot sustain spontaneous ventilation and needs to be intubated. So for those patients with progressive neuromuscular disease, someone who's like Guillain-Barré, as Lori will talk about, those patients, what we'll do at the bedside is sequentially, over every couple of hours, measure their slow vital capacity to see if they're becoming weaker. And this is out of Egan. I kind of like it because it talks about as your vital capacity deteriorates, what kind of pathophysiology which will you end up seeing, and what kind of therapy may be indicated. So we'll come back and reference this triangle quite a lot during this course, because it's going to be how are we going to intervene on the part of the patient. And you can see once you get below 15, we need positive pressure and probably full ventilation as far as that. So let's do this. If you want to practice EKG, you can go ahead and do that. If you want to familiarize yourself with the machine at the very least. And on tomorrow, what we'll end up doing is we'll end up doing demos on the respiratory mechanics stuff, because I think that PE comes pretty closely after the EKG one. And the EKG one, I believe, is next Wednesday and Thursday. Does that sound right? So we'll have some time to practice today. I will be in here on Friday, so if you want to come in and practice on Friday, you're welcome to do that. I know you want to see me 5 days in a row. Deep down, that's what